Good afternoon, everybody, and it's almost 1:05, but I think we can get started. And it is my pleasure to welcome to the colloquium this afternoon Jacqueline Ndlovu, who is a PhD candidate at the University of Copenhagen's Department of Public Health, the Global Health section. She has a master's in global health from the same institution, and her research focuses on integrating interventions into multi-sectoral humanitarian programs, particularly for refugee populations, with a strong emphasis on mental health service delivery and scalability. She's passionate about making mental health services more accessible and effective, and she's driven by translational research, implementation science, and building equitable partnerships to advance public health initiatives. Jacqueline, it's a pleasure to have you here this afternoon, and we very much look forward to your talk. Thank you so much.
Thank you so much, Bronin. It's a pleasure to be here. I had the opportunity to actually be at Stellenbosch University last year from October to December. I had a change of research environment. So our university kind of sponsors students to go to other institutions and connect with other people working in the same field. And Professor Kagi, who I see is joining us today, was kind enough to allow me to be at Stellenbosch, and I was also hosted by the University of Cape Town with the Alan J. Fleischer Center for Public Mental Health. So it's great. I feel like it's like being back. Right. Okay, so I'll just share my screen. Okay, can everybody see my screen?
Yes, we can, in full view. Thank you so much.
Okay, great. All right. So as Brandon said, my name is Jackie, and I'm a PhD student at the University of Copenhagen. And I actually handed in my thesis in August, and I will be defending it in the upcoming months, most probably November. So this is kind of getting back into the groove of my research. And so today I'll be talking to you a little bit about what my PhD research was on. And I was working in Uganda with South Sudanese refugees and also with healthcare workers in Uganda. And the whole aim of my PhD is to kind of look into how can we scale up mental health and psychosocial services in a way that can forward sustainability. And I was using a guided self-help intervention called Self-Help Plus. So just for a bit of background, okay, looks like I'll have to do this. Yeah. So just for a bit of background into why it's important to scale up mental health services, I won't go into what mental health is and all of that in the interest of time. So about 1 in 5 people in humanitarian crisis settings experience mental health problems. And the most significant thing about this is that they don't only experience these challenges at the point of contact with the crisis, but it follows them throughout their lifetime. So it's quite a significant number to work with. And then there are some mental health and psychosocial interventions. So I'll just say MHPSs for short, that show very strong evidence. But the challenge with these interventions is that they're very difficult to bring to scale. And looking at the number that I said, it's like 20% of the population affected by humanitarian crisis. So that's quite a large number. So we have to find ways of bringing mental health services closer to people who actually need them. So there are 3 main challenges with the current interventions. And the first one is that they require skilled specialists like psychologists and psychiatrists. In any normal setting, we know that the ratio is not optimum. So when it comes to humanitarian settings, you can imagine that we have even less people who are specialized to work with mental health. And then these interventions also they reach individuals in very small groups of up to 5 people at a time. But we need interventions that can increase their reach, looking at the number of people in need. Another challenge is that these interventions only address one mental health problem at a time. But research has shown us that people who have been through a crisis, they experience mental challenges more broadly. So you can have someone who has post-traumatic stress disorder, anxiety attacks, all of that at the same time. So we need more transdiagnostic interventions. So the WHO, some university partners, and other stakeholders came together and they developed Self-Help Plus to directly address these challenges. So in the next slide, I'll go into more about what SH Plus is. So Self-Help Plus is a low-intensity guided self-help stress management course. It provides ways of managing psychological distress and coping with adversity more broadly. So it's not very specific. It works with a very varied number of mental health challenges at a time. But it's important to note that Self-Help Plus only works for people who experience mild to moderate mental health challenges. So for the more severe challenges, it wouldn't work. And people with those kinds of needs are then referred to services, especially in healthcare settings where they're able to get the help that they need. Another important factor about Self-Help Plus is that it's delivered by non-specialists. So these non-specialists can be anyone who can read and who can write, and they go through a 1 week intensive training exercise. And throughout the training, they also have competency assessments to see if they're capable of delivering the services, and after that, they're able to go on and deliver Self-Help Plus. In terms of the format, so I'll just say SH Plus just to make it easier. So in terms of the format, we can have up to 30 people sitting in a Self-Help Plus workshop. And these workshops can be run anywhere where there's space, where the people can get together and sit together, and where you can actually run a portable audio speaker. So the sessions are delivered over a period of 5 weeks, with one workshop running every week. And it consists of two main materials. So the first is a pre-recorded, highly scripted audio that the trained non-specialists are kind of trained to stop, to pause, to work through the exercises. So the audio is very scripted, and there's not so much that the non-specialists can add to it. And then it also consists of a self-help book. I included the book here. It's the Doing What Matters in Times of Stress, and it's publicly available through WHO. And with the book, the participants are able to take it home with them to kind of reinforce the key concepts that they learned during the Self-Help Plus workshops. So it's a nice reference book to take home with. So coming more into what those weeks look like. So in the first week, participants go through grounding, which is more of activities to bring our attention back to the present moment instead of having all of these emotions and thoughts, these distressing thoughts being caught up in an emotional storm. And then in the second week, the participants go through unhooking. And unhooking is a skill that participants build to help them remove themselves from difficult thoughts and feelings. And they do this by noticing what they're feeling, noticing what they're thinking, and naming them. And then through this process of actually acknowledging what it is that you're feeling and giving it a name, then you're able to focus on the present moment more. And then in the third week, the participants go through acting on your values. And this is more of ways of identifying what the participants' personal values are, and then also working through some of the behaviors that they can do to reinforce these personal values and act in a way that aligns with the values. And then in the fourth week, the participants work on being kind. And I think for most of us, we find it very easy to be kind to other people, but we also kind of emphasize being kind to yourself as well. So directing kindness inward and outward. And then in the fifth week, we go through an exercise of making room. And this is more of an advanced technique of unhooking. And through this technique, the participants are able to acknowledge what it is that they're feeling, to give themselves the space and the to give themselves the space to feel what they're feeling, and then allow these thoughts and these feelings to come and go instead of fighting with them. So this is what a 5 session SH Plus workshop looks like. And we all have one session running a week. So the first week, when you go through the exercises, you go home, you read the book, you kind of work through all the activities for that week. The next week, you come, you get another skill set, and then you do all of this for 5 weeks. And then coming more into SH Plus implementation context. So the WHO developed this around 2015, 2016. And then there were 3 primary research groups who took it up and tested it in different areas. So in Uganda, it was tested with South Sudanese refugees by Vitsa Toll, who is also my supervisor. So my research is based in Uganda because of this. And then in Uganda, it was primarily, we first wanted to test it with all South Sudanese refugees, but then we realized that there were gender dynamics that came into play. So men had different needs and women had different needs. And then we ended up testing it with women. And then with men, we found that alcohol was another factor that we had to take into account, looking at the social determinants of mental health. So in the following years, we developed something else that could include an alcohol component to it. I'll speak a little bit more about it later on today. So in Uganda, SH Plus showed reduced symptoms of depression and anxiety, and there was a very high acceptability rate among participants. And then in Turkey, SH Plus was piloted with Syrian refugees who were living in Turkey, and it was shown to be effective in addressing trauma-related symptoms. And then in Europe, in a multiple center study, I think there were about 5 European countries, SH Plus was piloted with refugees and asylum seekers, and it was shown to be effective in reducing mental health symptoms. And then across all of these studies, SH Plus was found to be safe, effective, highly relevant, feasible, and acceptable. And there was a very heavy emphasis on implementation outcomes, as you can see. So there are other studies that have also worked with SH Plus from then, but I didn't include them right now. Most of them are ongoing. I just wanted to show like the formative picture of where SH Plus started and how I came about my PhD. And then following all these very good results, the next step was to scale up. And in Uganda, we decided to scale SH Plus through multi-sectoral integration. So multi-sectoral integration in our context is when we integrate a mental health component such as SH Plus into other sectors. So generally other sectors, this can be livelihoods, protection, nutrition, all the other different sectors outside of healthcare. So here I'll just show the overall framework of my PhD and where I'm situated before going into the specific project that I was working on. So the main aim of my PhD is primarily to understand implementation processes and strategies that are needed to feasibly scale SH Plus through multi-sectoral integration. And so for my PhD, it's paper-based. I have 3 papers that make up the entirety of my PhD, and these are divided into sub-study 1 and sub-study 2. So the first sub-study was a systematic review where I wanted to kind of get an understanding if there are any interventions, any psychological interventions that have actually scaled through multi-sectoral integration. And from this study, I had 8 very conclusive studies. So it shows that there are not so many studies that have actually integrated outside of the healthcare system. And this kind of built into the second sub-study, which is more qualitative in nature. So I won't go into the research questions. I'll just kind of give an overview of what these studies are. So for my second paper, I focused more on evaluating relevance, acceptability, and potential scalability of SH plus with male refugees in Uganda. And like I mentioned earlier, in the formative work, we focused on the female South Sudanese refugees. And then for this paper, we built on a study called the SH plus men study, and included an alcohol component. And then we wanted to see if this combined intervention where we have something that works on alcohol and then something that works on mental health can actually be relevant and acceptable, and can we scale it to other people in the communities. And then the third paper, which I will focus on primarily today, is focusing on scaling mental health services through integration. And this is a qualitative paper where I looked more into the factors affecting delivery and uptake. So more into what are the facilitators, what are the barriers, what do we need for us to be able to scale through multi-sectoral integration. And we did this with South Sudanese refugees and healthcare workers in Uganda. So this is the overall framing of my PhD, and right now I'll go into paper 3. So the project that goes with paper 3 and the research that came out of that. Great. So the project for that one is called Journey to Scale. And we called it Journey to Scale because we wanted to learn how to scale. We were not scaling, we were learning how to scale. So yeah. The name kind of explains itself. So the Journey to Scale SH Plus project is kind of a technical tailored support model that we called Self-Help Plus 360. So moving beyond the normal delivery of SH Plus and adding 360. And the 360 here essentially means that we provided technical tailored support to partners across the project cycle. So here in blue, you can see some of the steps that we include. So we go with partners from assessing the needs of the community, the needs of the partners. What do they need when they are incorporating mental health into their programming? And then we go through processes where we translate and adapt materials. And then we train the partners to deliver SH Plus on their own. And then we implement together with the partners. And then throughout this whole cycle, we go through a series of monitoring and evaluation. And we also kind of work together with the partners to create a monitoring subsystem, you can call it, which is specific for SH Plus. Because it's important to maintain quality. So we make sure that we include those processes into integration. So in the Journey to Scale project, we partnered with an international NGO called BRAC Uganda. and then a local partner, the Ministry of Health. And with these two partners, we kind of tested how we could integrate SH Plus. And we did this by integrating with livelihoods programming, with financing programming, and also within the healthcare system. So kind of testing inside the healthcare system and outside of the healthcare system to kind of see the differences with that. And the main reason why we chose to scale up through integration is because, so like I showed before, the burden of mental health challenges is quite great and the treatment gap is enormous. So the number of people who need care and the people who actually receive care. So the difference between those two is quite big. And by integrating into services that don't have a mental health connotation to it, we hoped that we could minimize stigma and discrimination that often comes with mental health interventions. And we partnered with very large organizations who are already operating at scale throughout Uganda. And by doing that, we hope that we would enhance access. So instead of us working through how we can add on the services from community to community, we could already take advantage of organizations that were working at scale to bring the services much faster to people who needed them. So with the two partners, with BRAC Uganda, I'll start with BRAC Uganda. So BRAC Uganda works with South Sudanese refugees and host communities at Rhino Camp Settlement for Refugees. And here we primarily focused in northern Uganda because BRAC did not have any mental health programming in that area. And they were very interested in starting to bring those services as well. So it was kind of a pragmatic choice, and we left this up to BRAC to choose where they would want to have mental health services. So we worked with the South Sudanese refugees and host communities, and also with BRAC staff. The staff involved in programming, in monitoring and evaluation, and in finance. So we kind of had an idea that for us to be able to integrate successfully, we needed the staff to lead on activities and to take ownership of these activities. So in terms of financing, monitoring and evaluation and programming, but we also needed them to take into account their target impact group needs. So it was kind of a top-down, bottom-up approach, if you can call it that. We also worked with intervention facilitators. So these were people who were already working under BRAC Uganda. They were community volunteers and they were trained in delivering SH Plus. So in northern Uganda, we reached about 2,500 people. So about so they all went through the 5 weeks of training in SH Plus. And then in the Ministry of Health, we kind of have a different setting, but the principle is still the same. We still worked with the healthcare staff, also in programming, monitoring and evaluation, and finance. But the target impact group here was healthcare staff. And the ministry was more concerned about their staff who had been in the front lines during the COVID-19 pandemic. So they chose those staff to go through SH Plus. And then the intervention facilitators from the Ministry of Health were mostly social workers, nurses, and counselors. And we worked in 19 healthcare facilities in the capital Kampala and the surrounding areas. And with the Ministry of Health, we reached about 560 people. And then now coming more into an overview of the project. I know this is a very busy slide, but I just wanted to show the 2 phases of the project and how we went about implementing together with the partners. So the first phase was more of a development phase where we got together with the partners, and in that phase, we initiated the partnerships. And when we already had the partnership, especially with the Ministry of Health, we went through some activities to kind of solidify that partnership. And I cannot stress enough how partnership actually lays a very, very important role in terms of successful implementation. And then together with the partners, we went through a process of co-creation and co-development. So we worked together to work on an implementation plan, to build a budget, to build the project timeline. So all of this was in collaboration with the partners. And when we had an idea of how the implementation was going to work, we went into the second phase, which is more on the project cycle. So we started off with the needs and resource assessment. And here we were mapping the needs of the partners from an organizational perspective and also the needs of the target impact group to kind of see how we could tailor and adapt the SH Plus materials to meet these needs. Then we went through a round of translating and adapting these materials. For example, so SH Plus was first tested with South Sudanese refugees. So it was in that language. And then for the healthcare workers, we had to translate that into English to make it more accessible to the healthcare workers. So those were the translation and adaptation processes that we went through. Then after that phase, we went through a round of training from both RAC Uganda and the Ministry of Health. And we also trained research assistants to be able to collect data, to analyze, to monitor and evaluate. And then we went through a short phase of implementation. So with BRAC Uganda, we went through one cycle of SH Plus implementation, so 5 weeks of the sessions. And then with the Ministry of Health, they really wanted to be able to keep delivering the services even after the project had ended. So we went through 2 cycles. So the first cycle was training, a 5-week training on SH Plus, and then facilitators received additional training as TOT, so training of trainers. So they kind of had the capacity to train more people and to expand the services to other areas, even after the project had finished. And then in terms of monitoring and evaluation, we had different activities across the project cycle. So pre-assessment, process evaluation, some post-assessment, and the research assistants mainly worked in that piece. So this is kind of the overview of the Journey to Scale project that my PhD is embedded in. So this is more on the practice, on the practical side, and now coming more into the research from that project. And that's where my last paper, paper 3, comes from. So the aim of that paper was primarily to explore factors that affect SH Plus delivery and uptake at scale through integration. And here we're looking primarily into barriers and facilitators of SH Plus delivery. So we collected data at 2 time points. So first we collected data during the needs and resource assessment before implementation that I showed you. And we also collected data after implementation, so through process evaluation interviews. And we talked to the partner staff, we talked to the people who were facilitating the sessions, so the intervention facilitators, and we also talked to the target impact group, so South Sudanese refugees, the host communities, and the healthcare workers. And overall, we had about 50 interviews from these 2 phases. In terms of findings from this research, overall, it showed that SH Plus was well integrated into partner programming. And it was, so we have some facilitators, we have some barriers, and then in other times, these were kind of cross-cutting. So I will just speak a little bit more about that now. Right. So some of the facilitators were that SH Plus is a simple intervention and it can be adapted very easily. And because of this, the partners were able to kind of integrate it into their already running programming. And then another facilitators is that the partners were able to build their own internal capacity to implement SH Plus on their own, particularly with the Ministry of Health, who also had people training as trainers of SH Plus. And then the co-development and the co-creation phase also helped both us and the partners to come up with intervention components that worked well within their organizations, within their structures and systems. And then the fact that SH Plus is kind of delivered in a group setting was also identified as a motivating factor for most of the participants. And so first identifying the needs of the stakeholders at the beginning helped us to really adapt the delivery of SH Plus. And overall, there were very evident stress management effects that were felt from the very first session. So these were kind of the primary facilitators. Then in terms of some of the barriers that were raised, the first is that so integration as a concept was kind of understood differently across all the stakeholders. So with partners who had been involved from the very beginning, who had a lot of say in how the project was going to be implemented, they understood integration very well, and they also could see the different aspects of how it worked and how it didn't work. But with the target impact groups, they still felt like there was a SH Plus project and then a project from the partner. So they took this in isolation. And we think that it was because we involved them a little bit later than, and then if we had involved them from the very beginning, we would have had very different results. Another barrier is the financial support and funding structures. And this is mainly because of the need to be more sustainable and to have continuity. So it was very difficult, particularly for BRAC, who are financed by third parties, and all of this funding is restricted to kind of make space and make room for an additional component. And for that, they would need to apply for grants and funds again. So that was also another challenge that we experienced. And then another challenge was language barriers and translations. So because we were covering a wide geographic area, there are a lot of different variations in terms of language. Even the Juba Arabic that is spoken in northern Uganda has different variations. And a lot of participants had to have like additional translators in the sessions, and this was recognized as a barrier. And then one thing that we did not foresee was that the partnership development phase was actually going to be very time and resource consuming. And I think I did state earlier that we really have to put more emphasis into developing partnerships and making sure that we have very strong partnerships to be able to implement successfully. And I think this goes into the funding structures as well. If we can have more, I don't know, more funding for these kinds of phases, because most of the time funding only starts when you're implementing, and then there's not so much money that goes into taking time and resources to build these partnerships. Yeah. So in the next slide, I just wanted to show you the 5 main themes from the paper, and a little bit more on the responses that we got from some of the participants. So I did talk about the simplicity of SH Plus, so that goes with the adaptivity. And here we have a BRAC, the top quote, a BRAC Uganda facilitator saying that delivering SH Plus is so easy. You can deliver knowledge and information for someone without deviating from the meaning because it's audio recorded. It makes someone understand better. So the facilitators found it really easy to implement SH Plus. And then something of note that I wanted to show was the second quote, where a staff member here is saying that when a person doesn't have a clear mind, they cannot be able to handle anything given to them very well. So this shows that while we are looking into other social determinants, mental health is quite important for the success of all the other interventions. And they go on to mention that. So they say that I move forward a bit quickly. Yeah. So they say that they will not be able to keep the goals that you support them with. And even when you talk about protection, gender-based violence, and so on, someone may not be able to handle them very well unless you support them with mental health and psychosocial support. Right. Okay. And then another quote that I wanted to highlight today was one from the BRAC Uganda participant who felt that they did not get the support that they needed. So going beyond, it's well and great that we have mental health support, but we also have other needs. And if those needs are not taken care of, how are we able to manage stress? And our main aim of integrating was to address this specific problem. But it seems like we need to put more emphasis and to work to adapt the interventions more into making sure that participants kind of have a holistic intervention that addresses more than one need at a time. And then coming into sustainability, the last quote from one of the partners shows that, anyway, it says, just imagine if we were to expand SH Plus to other places and for more years, it would really have an impact on the people, because MHPSS is one of the areas that is less implemented and not really taken seriously, and yet is very important. So all of this highlights kind of the findings from the paper and makes a case for why integrating with other sectors is important, particularly for mental health. So some of the takeaways from my PhD and this paper specifically is that the research on multi-sectoral integration really supports the need for these types of integration of mental health interventions. So as mental health practitioners, I can say, we need to look more outside and more into other sectors and see how we can work together, because working in silos is it's not very optimal. And then the practices in partnerships and co-creating and working together with the communities that we work with should be explored further to enhance scaling. And this was shown in the quotes that I mentioned, where social determinants are not addressed as well when we don't create together with partners. And then the last takeaway I'd like to mention today is that building on the need for integrated interventions and the interest from partners. And this goes beyond our project, because while we were working in Uganda, we had a lot of interests coming up. But for most of those partners who wanted to take this up, funding was a major barrier. So funding structures really need to be adapted to accommodate for this added value of integrating across sectors. And I think right now we are not doing a very good job of communicating the added value. Great. Thank you. I will stop sharing my screen and I hope we can have a great discussion on this.
Jacqueline, thank you so much for a very interesting talk and certainly incredibly important work. I think this journey to scale is like, it's an absolute apt title, because it's probably one of the most difficult things to do, is to try and scale the work, which is, I guess, where this whole field of implementation science comes up. And you gave us a glimpse into what that was like for you, which sounded like an enormous amount of work. So thank you so much for sharing that with us. Colleagues, is there anyone who has a comment or a question for Jacqueline? Please, please raise your hand or just unmute yourself if you have a comment or question. I'm sure Jacqueline would be happy to answer these. Okay, so while we give people a minute to think, Jacqueline, I wondered, it's clear that you had done quite a bit of work in the beginning to involve your partners, so to involve BRAC and to involve the healthcare facilities. And yet you said near the end of your talk that more could have been done to involve them from the beginning. I wondered what did you mean by that, and what more would you have wanted to do now in retrospect?
Okay, I think we did quite a lot and into involving the partners, so the staff and the people who were implementing, but not so much into involving the target impact groups. So that was kind of the disconnect there. And although the partners did an assessment with the target impact groups, it was mostly just an information session. So we could have had more of their representation when we were co-creating and co-developing all the materials. So that disconnect really showed in our results. Yeah.
Okay, so more people, refugees who are accessing these facilities.
Yes.
And I don't see a hand or a question yet, so maybe I can just follow up with one more. But can you talk to us a little bit more about the realities of this implementation within, for example, the healthcare services? So when exactly sort of was the intervention delivered as part of the package of services that are provided there? So if I was a refugee, was I then able to receive this package if I came searching for mental health care specifically, or was it, or how did I get access to this when I attended a facility?
Okay. So for the South Sudanese refugees, we did not deliver this in healthcare settings. We only did that for the Ministry of Health. So with the South Sudanese refugees, we delivered this with people who were already in their programming, so in the financing programming and in the livelihoods programming. And so they got together in groups and then they could, while they were receiving all the other interventions, then we could add a mental health component to it. So it was more community based, you would say.
Okay, so they would already be in these groups attending
Others,
every week, and
yes,
then this was an additional package added on, so then they would just stay a bit longer to get this mental health support as well.
yeah. hmm
Okay, and then through BRAC, how did that work there?
That was through BRAC. So BRAC primarily focused on the South Sudanese refugees and also on the host communities.
Okay, and then in collaboration with the Ministry of Health
And then with the
yeah.
Ministry of Health, it was kind of a different intervention. And we were working with healthcare workers who were already in the healthcare settings, so in the hospitals. So while they were Yeah, so they would have to take time off from all the activities and attend the sessions while they were in the hospital setting.
Okay. And how did they, and to that they responded well?
They did respond well, although participation was kind of on and off because they're very busy sometimes, and then you can't always predict how busy they are. And yeah.
Yeah. We have a question here from Dr. Philippa Hain, who says, brilliant work, Jacqueline. I've noted that Self-House Plus targets adults as a population. Are you aware of whether it's been adapted for use with adolescents?
All right, that's quite an interesting thought, and I think it would be very helpful to go more into younger age groups. But right now, it's only for adults, so aged 18 and above, and there hasn't been any work on SH Plus with adolescents or with children at all.
So perhaps something future to look into.
Definitely, yes.
And so where to next for you, Jacqueline? How far are your papers? Are they all published? Are they under review? Can we have access to them if they are? And what are some of the next steps for you?
Right. I've had 2 papers that have been accepted for publication, so we're going through the process. And then one paper that I'm still going through the whole review process. And then I will be having my defense in a few weeks. Yeah. And then right now I'm kind of working more in partnerships and grant management because I think from my PhD training, I could see that yeah, I couldn't do research in isolation. Also had to know more about all the other processes, and that's where I'm situated right now.
Excellent. Well, good luck with all of that. And thank you so much again for this wonderful talk. And to everyone who attended this afternoon, thank you for making the time. And I will upload your talk onto our YouTube channel and share the link with you for your own reference, Jacqueline. So thanks so much again, and have a wonderful week further.
Thank you so much for having me.
Sure. And good luck for your defense.
Thank you.
Okay,
Thank
bye-bye.
you.
Bye.
Bye.